morning, everyone. I'm Vanessa Guzman, and welcome to a session that is not just about best practices and driving change in healthcare, but is honestly a call to wisdom for me. It's discussing the gravity of the so many changes, the amount of noise, the fact that a person's zip code is still a predictor of their health status, their mortality. And this year, the landscape in healthcare has really significantly changed the way that we look at healthcare, how we evolve programs, how we support and fund those programs, and really the importance that we've seen in the shift from policymakers and how it's intertwined into some of the politics this year has made me really feel the inclination to have conversations over how do we anchor ourselves as individuals into our personal mission, into our professional leadership to really bring change that we desire to our communities, to the patients that we serve, to the organizations that we often work with or work for. And with that, the demands that our day-to-day requires from us. And there's a level of wisdom that we need in order to combine the intelligence, our lived experience, the drive to do our work, to really have an impact and have the opportunity to use this time of disruption to drive not only moral responsibility, but also measurable change. So I'm honored to introduce the leaders who, in my opinion, are doing exactly that. Stephen Rosenthal from Montefiore. We also have Jasmine McLean from the Health Management Academy, Dr. Lou Hart, a physician and CEO, and Carrie Gillespie, financial leader who translates human value into a champion ROI. And I really feel that this group is what not only well positioned to have this conversation today, but I am really feeling good about getting a little wisdom from all of you today. So, welcome everyone. We're going to start with a lightning question for everyone to answer, and and I really believe that the only way to navigate this landscape is to start with anchoring ourselves. So the question goes for you, Steve. Stephen, you can start first, and then we'll pass it on to Dr. Hart and Jasmine, and then Carrie. Is what lived experience, perspective, or personal values anchor how you show up as a healthcare leader? And how has that shaped your world as far as how you see it? And also like making patient-centric decisions as you go day to day.
Well, I've spent the bulk, if not almost all of my career in communities in need and diversity. And for me, from day one, it's always been all about the patient. And I've always focused on the challenges that individuals have been dealing with as part of my rationale for growing up in healthcare, starting out as an audiologist dealing with children's complexities in language and hearing to living through these 45 years of change and change management. So I stay focused on the patient, stay focused on the challenges that they face, and create a little bit of compassion and empathy wherever I try to go. And that's really been my driving force and what gets me up in the morning.
Thank you so much, Stephen. That speaks to me, and I see it every day in the work that you do, and I see it every day in the work and how it's reflected in the community in the Bronx and Hudson Valley, being local to the Montefiore Health System arena. So thank you for your leadership for so many years. And Dr. Hart.
Thank you so much, Vanessa. It's really exciting to be here with, as Jasmine put it, such an illustrious group of individuals. I feel very privileged to be alongside such heavy hitters in our industry. I really love the question because it allows me to kind of bring my whole authentic self. And it's really what I've been trying to do my entire career. I've been practicing medicine for about 10 years now, and I'm a pediatrician. And I've worked in various health systems. I've trained in different parts of our country, from Nashville, Tennessee to La Jolla, California, to New York City, in Manhattan, in the Bronx, and now up in Connecticut. And it's ironic because I was born and raised in Western Canada. So I've had a true North American experience and have seen healthcare and how that shows up in various parts of our country differently. And, I came into medicine believing that if you worked hard and kind of followed the evidence, treated people with respect, the system would kind of take care of the rest. But very early on, I realized and I found out that's not exactly true. I saw two patients just recently with the same diagnosis, one insured and one uninsured, and the care they received was very different. Happened to be at
Mm.
two different hospitals within a system, but it was very eye-opening to me. And at some point, it becomes just an everyday experience and an everyday occurrence, which is something that I never want to become naive to or numb to. I've seen how algorithms that are built in our electronic medical record assume a patient's biology based on their race and recommend different treatment plans on the basis of a social identity like race. This is at the same time as organizations, we refer to ourselves as high reliable organizations with a reluctance to simplify. But yet we take a social category and impute a risk prediction onto a person and say, this is your risk of this disease. It really is starting to get to a point where I'm realizing that where we are now is so far from where we need to be. And it really requires a fundamental understanding of how we got here and who the current system benefits the most for us to really unearth what a better system could look like for all of us, including those who the system has now been currently designed for. A lot of the experiences I had were really solidified. I trained at NYU Bellevue, and I saw firsthand like what a segregated healthcare system looks like. The systems that we've built and that we continue to preside over everywhere in our country today, having public hospitals, having tertiary, quaternary academic medical centers, and the different access that is afforded to patients based on insurance, based on language, based on zip code, and social resources that go along with that. These experiences have given me a lot of clarity. I used to think that, the practice of medicine isn't just about applying science, it's about applying conscious. I want to say like the three values that bring me the most into this work are probably fairness, accountability, and transparency.
Ooh.
Fairness, because I've seen how much brilliance and potential is lost when systems treat some individuals as less worthy of investment. Accountability, because I've learned that intentions don't change outcomes, measurement and governance do. And it really requires that intentionality and not just goodwill or a desire for change, but really holding ourselves accountable if we ever are to get things done, because the path of least resistance is status quo and the inertia can sometimes be insurmountable. Finally, I would say transparency, because sunlight is the best disinfectant for both bias and bureaucracy. It's probably the sad part of working at large health systems and having the privilege of having leadership roles is I've seen how slow change occurs and how some of the incumbents benefit from so much bureaucracy, which makes change management very difficult and which makes continuous quality improvement almost impossible in certain settings. So really aligning purpose with performance, it's really been fundamental for me. I feel very privileged early in my career, just out of residency training, to have opportunities to advance my professional training in clinical leadership fellowships and getting an executive MBA as a Posen Commonwealth Fund fellow here at the Yale School of Management, which has afforded me opportunities to rise into leadership roles and executive level roles relatively early in my career. But I do not take those for granted. But I've kind of seen both sides of the further and further you get away from the patient. And yet at the same time, I've always practiced 50% clinical as a pediatric
Yeah.
hospitalist at our children's hospitals across the state. So it's just been very fascinating to kind of see both dualisms. And I always remain grounded in the humanism of what we do and what we're doing. When we think about health equity, like too often it's been viewed as charity work, but this is strategic work, because every time we close a gap in trust or access, we close a gap in cost too. So I'm just really excited to talk a lot about and hopefully delve into more on this panel with my esteemed colleagues around how we might re-envision and redesign what value means and the traditional value equation, because for the longest time it has not included the human perspective. So excited to be here and excited to learn more from my colleagues and hopefully share a few good lessons learned.
Well, how lucky are those kids that get to see you, Dr. Hart? Thank you so much for sharing your wisdom. And I like you, I want to believe that, patients, consumers, people have agency over their, understanding what their needs are and obtaining the resources that are necessary for that. Knowing that they're not going to be the same, going back to that, seeing two patients with the same diagnoses. But I also feel that we can be activists of our own health because we see ourselves most of the time, right? There are things that are suppressed or oppressed by the system, but there are also things that as patients we should own because we carry ourselves all day long, but we need to be empowered to act and own that fact. So thank you so much, Dr. Hart. And then Jasmine, what about you? What anchors you every day? You work with a bunch of stakeholders, so I'd love to hear your thoughts.
Yeah, as you asked the question, I think there were three things for me that came to mind. The first is I think I see the world through the lens of a scientist. I trained as a cancer researcher. I think I'm somebody that has moved through the world with a lot of curiosity. And so I think when you are engaging with folks of different backgrounds, of different parts of the country, and different organizations, that notion of really genuinely being curious about the perspective that other individuals are taking and asking good questions, I think has been a really important part of how I think about my career, how I think about the work that I do around health equity. And so that is something that I think has served me in many ways and drives me in terms of how I show up for the work that I do. The second, I think, is, having had a very informative and sort of just meaningful experience very young of watching a family member die in her 20s of cancer. And she was a Black woman in the South, and just watching not only the devastation that that entailed for our family, for her as an individual, but also really thinking about issues of health literacy and social networks and safety nets that didn't exist, and just really navigating that experience, I think was meaningful for me at a very young age. And so that is something that I kind of use as a touchstone, I think, as I have conversations with health system executives, with folks across the healthcare landscape, that, the stakes are life or death for
Mhm.
many folks in our country, and really not losing sight of that in healthcare as it's become such a large proportion of how we think about, the operations of this country, as we think about, the amount of GDP that we allocate to healthcare over any given year. I think that's something that really is a good reminder for me. And the last piece I would say is I'm somebody that is a very keen observer of power and systems. I think, as Lou was kind of mentioning, I was thinking about this. I think a lot of that comes from having lived in different parts of the country. I was raised in Georgia in the South. I've spent, greater parts of my life in California and in Southeast DC and in the Mid-Atlantic. And so really thinking about what you learn when you're slightly outside of a
Mhm.
system is something that I
Mhm.
reflect on a lot. Often I'm in positions where I sit within a healthcare organization, but I'm sort of watching a little bit from the outside. And I think that perspective is really helpful when you have some distance from how
Mhm.
decisions get made, from sort of power and influence, and the way that that plays out in bureaucracy, and sort of the way that, strategic priorities may get elevated or deprioritized. And so that is something I think about a lot. Certainly in my role at the Health Management Academy, we work with leading health systems across the country. And so I think really taking that perspective of how and why we make decisions is something that motivates me in my work.
And I see that every day, that curiosity, that is almost childlike, Jasmine, and it's beautiful that I see it every day in you. And I learned this year, and even going to next year, that it's not about having answers necessarily as leaders, although I love that too, but
Hmm.
it's also having really smart questions, because that drive us deeper into discussion. And having
Mhm.
these type of dialogues, we learn from each other. It opens up to something else that we perhaps have created limitations around. And I think that often happens with our own patients. They're afraid of asking questions, right? They're afraid of becoming vulnerable, even though which best, relationship would they have than vulnerability with their provider, right? But that's generally not the case. And it goes back to Lou's comment around trust, right? And building that trust with patients and having open dialogue. And I think that stems from curiosity, trust, and also feeling a sense of a pride of where you started, of where you came from, including those lived experiences that perhaps are sadden us, or brings us back to a moment in time, like you explained, that just highlights a need versus something that's memorably, a happy thought. So thank you for sharing that, Jasmine. And then lastly but not least, Carrie.
Thank you, Vanessa. So, first of all, quick background on myself. I'm a graduate of the University of Georgia, Jasmine. So
Go dogs.
we have that in common. Secondly, my background is mainly healthcare finance. I spent some time working in the public accounting sector, and then left and went right to the healthcare industry, and have spent my entire career in healthcare finance in various organizations. Most recently at Legacy Health in Portland, Oregon, where I was the interim CFO for almost a year and a half up there. So Gotta have a fairly diverse background in both for-profit, not-for-profit. Spent a lot of time in healthcare finance. If we think about the thing that anchors me, I think it's important to number one note what Dr. Hart said about the fact that we need to be curious, and that curiosity is important. If I think about the things that kind of ground me, the first one is our shared humanity. As we think about, I kind of am a scientific guy, and when I was a little boy, or a young boy, I read the book called The Double Helix, which was the story of the discovery and subsequent work around DNA. And of course, Watson and Frick were the main researchers there, both of them Nobel laureates. And of course, James Watson passed this past several days ago. And so I've been giving some thought to that. And it doesn't matter, of the 7+ billion people on this planet, every one of us shares, uh, you know, a, a DNA profile that is common to Homo sapiens, and we all come from the same DNA profile. That common shared humanity should be something that we all, in my opinion, should be something that we all embrace. And it means that it doesn't matter what my background is, what my biases are, what my experiences are. When I look at another human being, I should look at that person as um, part of my shared humanity, right?
Mhm.
And
Mhm.
as I relate to those individuals and work with individuals that have different lifestyles, different backgrounds, different whatever you want to say, different from me. My first thinking is to be curious about them, curious about what makes them tick, curious about their background, curious about how they relate to the world. That then allows us to be empathetic and have
Mhm.
empathy towards our fellow human beings, which then leads to a deeper understanding of what we need when we go for, as we go forward. I'm not, I'm not, the problem of cost is not lost on me in this country as we think about the cost of healthcare and how we get better at absorbing costs. But I think a lot of it starts with and I'm not going to get into the issues of insurers versus delivery systems versus whatever the case may be. I do believe, however, that we have to stop as a country pitting ourselves against each other and against organizations and figure out how to come to a common shared approach to solving the cost problem. Because if we as a country are not able to do this, then it will be a significant problem for us in the future as costs continue to grow, as healthcare continues to consume a larger percentage of our economy. It creates it makes the country be less competitive. It makes individuals be less of human beings, for lack of a better term, because of the way that their health is taken care of, or they take care of their health. And so there must be a common thought or a common process to how we solve this problem, and it must be solved. Otherwise, it'll be something that'll be problematic for us in the future. But yeah,
Yeah.
background, certainly the common shared humanity, the empathy of understanding each other, and the importance of being curious and of thinking about how to solve problems together rather than take care of our own is
Right.
I think is something that I'm very very passionate about.
Yeah, I love that. And I'm sure every organization who hears this would love to have you as their CFO thinking about the shared humanity behind the numbers. And I'm actually going, the next question, and I'm going to pivot us to now, like, how do you transforming, right? Leveraging or anchoring on that moral space that you all shared with us today into the financial responsibility. So many of our audience is going to ask, well, as a CFO, then what specific outcomes matter to you most behind the numbers to still capture that humanity, right? So I'm thinking, most of us calculate clinical excellence, quality, patient engagement, health equity strategies. All those things have measures, but when it comes to investing in certain programs that perhaps don't demonstrate ROI until much later or is a long-term ROI, which is often the case with healthcare community like strategies. Any thoughts on that?
As
Go
I'm
ahead,
sorry.
Steve.
Yeah, go ahead, Stephen.
As Carrie, as you were talking, I was thinking you were talking about finding a solution, and it came to me that, there are actually really no solution. There's really only choices.
Hmm.
And as we think through that, and we're in New York, we're becoming extraordinarily challenged on the financial side in healthcare, particularly at Montefiore, where 85% of our business is government programs. When the country gets a cold, we get pneumonia.
Mhm.
And it's a real challenge. And so you begin to think about your choices. And so we're living in a very interesting time where you've got this growth in technology that everyone's trying to understand and learn about, AI and all of that, growth in that. And then you've got all the needs of the community who are so separate and unrelated to this change in technology. So how do you begin to marry the opportunity
Mhm.
and make choices amongst the various opportunities or solutions that you can find that have the best impact you can have on the patient and that patient's family? Because what I've learned over time, and I think you pointed it out, is that you can make decisions about managing a disease process and coordinating the benefits and the solutions around that. Um, but then you can also begin thinking about the social challenges that are facing that family and beginning to recognize that those changes take time. How do you create a community of better housing? How do you create a community where there's better food distribution and better understanding of the needs of a family? And so those choices playing into the health system, it's almost as though we've become in many ways the governmental structure for a community. There's
Right.
nobody else out there thinking about what we're thinking about and what we're worried about in terms of the care of the population that we're servicing. And particularly as you were pointing out, that the children of the world are being born into this
Into this.
complex environment. I look at my own grandchildren and I'm saying to myself, wow, they got a really tough road ahead of them. I'm concerned that it's going to be much more difficult than the road I lived through, and I never thought mine was easy. So I'm beginning to wonder how hard could that be? So it's an interesting position, a moment in time, and I don't have the answers, but I think we all need to have a certain level of optimism because without it, you don't take risk and you
Right.
don't make
Yep.
better choices. And so together, I think we'll be able to make some decisions that hopefully will begin to improve the outcomes of the folks that we're trying to best manage and help deal with the complexities of our environment. I'll stop for a moment and perhaps others want to jump in or.
Yeah, yeah, and that's I love those comments because I feel that I have two questions for all of you from from that dialogue, Stephen. One is, what are those choices that all of you are seeing that are creating the best partnerships or bold programs that where we're seeing some momentum? I'm feeling very optimistic, but I'm also a business person who can see, okay, there are limitations on how much we can do at certain, instances in time. And in healthcare, there are always two things that are the least available: funds and IT folks to do some of the work. So I'm thinking prioritization. What have you seen? And I'm looking at folks like Jasmine and even Dr. Hart, from your vantage point and your moral responsibility, what are those choices that Stephen has talked about that you're seeing often that you feel really good about if we're talking about bold changes that we want to see in the next year?
We've been hearing a lot of conversations across the academy with, leading health systems around how they're thinking differently about community partnerships and this idea that as, organizations navigated through the COVID-19 pandemic, I think recognizing how the stakes are changing in terms of policy changes and really thinking about financial sustainability for the organization. I've heard, countless executives referencing the fact that, oh, we can't do it alone. We can't do it alone. And whether or not that is a revelation or sort of a reminder remains to be seen. But that is one thing that I think I'm really excited about, this idea that lived wisdom and lived experience really exists in a lot of pockets of communities around this country. And now not-for-profit health systems really sort of exploring what could partnerships look like as we move into the future, and how do we think about the tables that we're creating where folks can make decisions and really kind of have shared ownership and accountability around the way that we execute on our work to serve patients and communities in, the places that we live. I think that's something that really is important work, and is work that is high stakes and high reward, right? As you think about the fact that our social safety net is continuing to fray across this country, and really recognizing the fact that a lot of folks do not have access to the care that they need, the food that they need, the housing that they need. I think that's a place that, I'm excited to see where there's new partnerships that may emerge. For example, we just had a conversation a few weeks ago with Hawaii Pacific, and they're doing a lot of work around how they think about partnerships with the Department of Education, and really, bringing folks in to train them as surgical techs, for example, within the system. And so one of the things in this conversation that was really striking to me is the executive who was talking about this program said, often folks will go through this program with us, and, I think it's called the Academy of Healthcare Innovation, and they will become the highest income earner in their families as a result of getting access to that employment, right? And that is a game changer in terms of having access to insurance, really thinking about the new options that opens for families and communities. And so those types of examples, I think, are something that are things to keep our eyes on as we move into the next few years.
Yeah, I love that. And there is a need for structure and accountability, which you've all mentioned, but I'm calling it out again, to not only identify the right community partnerships to address the population's needs or the community needs, but in order for that to be successful in the long term, there has to be monitoring and evaluation on, is this relationship going? It's a relationship like any other. And it evolves with supply and demand, and really understanding both sides. How are services being expanded or impacted by virtue of this partnership, but how are patients engaging and how are they responding? And what I learned with our research this year is that, just for instance, rural versus urban respond very different. Just that one denominator, right? That there are other variables, of course, but that one variable determines a bunch of other things as far as accessibility, transportation, perception, the lens that they use, and how they understand and then act on care. So it's important that in that partnership that there is information that's informing how that relationship is evolving over time. And I think some folks get stuck, or they think a partnership is just a cool idea and they jump to it, which is okay too. It leads to a lot of innovation, but we also have to be smart in terms of how we invest our time, our dollars, and then what we're seeking as far as the relationship that we're aiming to have with our patients, because they're the primary consumers, obviously, of this work. So, Jasmine, that's such great insight. And then Dr. Hart, you had mentioned in an earlier comment when you first talked about moral responsibility in your anchors, the difference of seeing a patient that's uninsured and insured, right? So I want to deep dive a little bit, because this year we have a huge risk, given some of the Medicaid requirements that we are expected to implement later in the 2026 going to 2027. And there's a risk, there's projections on, the percent of patients that are going to become uninsured or not enrolled in Medicaid, and other risks associated with that. So tell me a little bit more as a doctor, what differentiates as far as practice, as far as care, as far as services? Why is it so different, right? Isn't it supposed to be you see a patient based on their condition and chief complaint? But tell me a little bit more about how you gather your thoughts on that.
Yeah, to your point, Vanessa, that's what all of our medical students and resident trainees believe. I mean, that's why they signed up for training for almost a decade of their careers, giving up their
Mhm.
20s to research and study complex disease and science for so long, thinking that they would have such a pure art and such a pure role to step into. And we rarely teach our trainees the business of medicine. I mean, it's a $5 trillion spend. It's approaching 20% of GDP.
Mhm.
Disparities in healthcare are rising at about a 6% compound annual growth rate per a Deloitte study in 2021. I mean, it's actually interesting the business model for disparities in our country, the business
Yeah.
model for fragmented care in a traditional fee-for-service system. I mean, this is what all due respect to my executive colleagues of not-for-profits. I've been on a few not-for-profit boards, community-based organizations, and rarely did those executives receive seven-figure salaries with bonuses in the six figures. I find it very ironic, and sometimes I think it's hard to kind of forget where you came from when you get so far away from the patient, when you're able to, through such hard work and dedication, amass so much financial resource and privilege, and often live in different parts of the community, often drive through neighborhoods that you would never send your kids to go to school in. It's really easy to forget where many of our executives who had humble upbringings kind of came from, and how easy it is to focus on, what's easy to measure. I mean, ultimately, our moral responsibility as healthcare leaders is to make sure that we don't, that we measure what reflects what we value. And many people would say we espouse these values of liberty, of fairness, of justice,
Mhm.
of improving care for everyone, regardless of their ability to pay. But if we only measure what's billable, we'll only improve what's profitable.
Mm,
It's not until we start to measure trust, fairness, and dignity alongside clinical efficiency that we'll build systems that are both high performing and human centered. I'll give an example that I think is really fascinating with, with whether that's ACA enhanced subsidies falling off or with Medicaid reimbursements
Mhm.
and really Medicare and Medicaid reimbursements lowering or not keeping up with the cost of providing care. Whether we believe that's true or not, just afford me that. I think it's really interesting that the prior business model in Connecticut, I'll give you an example. We don't have any managed Medicaid in the state. So Medicaid, our state insurer, only pays under fee for service. So a volume based, the more you do, the more you get. So there was very little incentive to keep people out of the hospital. Why would I pay to manage your diabetes in the outpatient setting when I can get maybe $60 for that visit? I have a financial incentive to have you have a diabetic coma or to have you have a stroke where I can bill neurosurgery. None of us would actually make that conscious decision, but if we have systems that are built to measure value, built to measure what's billable, built to measure what's profitable, how do you think we'll align our return on investment spend or making those financial predictions of should we build a new urgent care center in this part of town or should we build a new complex neurosurgical center of excellence where we might be able to do these advanced procedures and provide that access to care? So yes, we were able to provide, amazing acute care and emergency care to patients who might have a governmental insurer, but we were unable to provide a lot of the preventative care because there was no profit incentive to drive us that way. And we are not for profits. By no means do we have shareholders that we have a fiduciary responsibility. Our responsibility is to our community, but we also need to build new MRI machines and recruit more staff to be able to build new wings of our hospitals and of our clinics to be able to serve the need. And it's actually ironic. It's not. I've overheard and been in some rooms with conversations from some of our financial leaders who are saying like, the costs of care are not keeping up with the reimbursement we're getting from certain individuals. We're going to have to make necessary community investments to keep people out of the hospital, to keep people out of our emergency departments. The
mhm.
old kind of business model where disparities in fee for service kind of weren't that bad for business. Like you make much more money in your emergency department than keeping someone in clinic. So if they have to come, like it's not the end of the world. We'll provide the care there. There's now a huge burning desire to think like, how might we see undeniably that our clinical outcomes are heavily correlated. We're approaching a correlation of one between social needs and healthcare outcomes.
Yep.
And the idea that we could be so naive to say, no, we're just going to provide clinical care. We're going to provide the highest, best notch clinical care and be completely ignorant to those social needs or those health related social needs is coming to a point where it's just inexcusable and it's just irrational. So the idea that as medical, as healthcare, that we're just responsible for medical care and not responsible for
Mhm.
coordinating social care, given the fact that the social care is probably influencing the clinical outcomes just as high as some of our advanced procedures. So I finally am, this is where I'm optimistic, and this is maybe the Canadian in me, the consummate optimist, where as we, the people in Canada, finance our healthcare system, and it is far from perfect, but no one goes bankrupt getting sick in Canada. And we
Right.
do
Right.
provide amazing community resources. Our acute care
Mhm.
services aren't as robust as America by any means. But every pregnant woman or pregnant person who goes home with their newborn is going to get a home visit, at least two in those first 2 weeks. We're
Mhm.
also going to give a
Mhm.
year of paid leave to make sure that that mother or that pregnant person can be with their baby and make sure that those bonds can be developed early on in life. And we're going to support those children. When we think about cutting programs like Medicaid, it's like 75 to 80% of Medicaid beneficiaries are women and children. What are we doing? I mean, why do we think this is, and hopefully we have time to touch on, work requirements, which, there's a lot of evidence out of that Arkansas study in 2018 that
Right.
18,000 people were kind of kicked off the rolls. Employment didn't go up. You know what did go up? Emergency department visits. I mean, at the end of the day, we're going to pay for this one way or the other. We're either going to pay for this in the healthcare setting, or we're going to pay for this through appropriating tax dollars. We need to pay for it more efficiently and I think that's going to rely on us taking a real examination of how much social care or how much social sickness is really impacting clinical sickness. But for the longest time, sick patients were good for business. And I finally think when that business model becomes disrupted, that we'll all, from the front lines to our most senior, well-intentioned of senior leaders, are going to see that, the only way for us to continue this is to do better and to innovate. But I guess necessity is the mother of all invention. And it seems that we are very much necessary for change right now.
Lou,
Yeah.
can I nominate you for office?
Thank you.
You
Thank
know,
you. Thank
what
you.
would you like to run for?
It's a scary country to be famous in. I don't
I
want
was
to
gonna
have to be
say.
attacked for beliefs. I always try to anchor myself in universalities and not partisanship, because as a lifelong moderate, I never make anybody
Yeah.
happy on either side.
Right.
Well, but that's politics today, right? Think about it a little bit. Look about what's going on in New York.
Uh-huh.
Um, as I'm listening to you speak, and I'm saying, there's an element of that's missing, and it's a combination of common sense
Uh-huh.
and empathy
Yeah.
as a combination. And I think we've lost that in some ways. And you look at some of the shows that are on television, and it's confounding, and it makes me sometimes feel very embarrassed about the way people speak and think, because you've just pointed out, a lifelong experience that I've gone through, as I've talked a little before. But the other thing too, I think, and all of us may feel the same way, is that I felt we were really making amazing strides.
Yeah.
And things were moving in a much more progressive way. And then it kind of like I felt like a wall got in the way, and I banged my head. And now I kind of am still a little bit dealing with the concussion, and I'm trying to figure out what's going on. And it's become a real challenge. But I appreciate what you said.
No, absolutely. And Stephen, and Dr. Hart's question or comment triggered a question for you, Stephen and Carrie, which is, you both obviously play in the arena of the financial component side of these things, right? Stephen, you really working in value-based care for over 30 years before you even had names to it, right? Like the ones we've mentioned today. And then Carrie, you in finance, funding these opportunities, and Dr. Hart said it best, right? It's gonna come at a cost, right? We choose where, what pocket pays for it.
Mhm.
The sad thing is that who pays for it is the people, right? So in addition to additional cost and inefficiencies and waste of time, there's mortality, there's disease, there's quality of life that's compromised. There's a bunch of things that matter because it's like people. The numbers reflect people at the end of the day. So how do both of you somehow converge that into how you carry discussions at a senior leadership level? Obviously, you're both senior folks at in the organizations you've worked in. What does that even look like? What is that dynamic when you're talking about this topic?
Well,
Feel heard.
no, I mean, it's a great point that you raise, and it's a complex issue, and it's often very difficult for folks to fully understand that haven't spent a lot of time doing it. But as you know, we've been looking at managing populations for a long time, and one of the things I've gleaned out of that, and I think some of it was alluded to in what Lou was just saying, is that I've always believed that if you focused on the quality, and you focused on the management of the care of the patients, and you ignored the differences between the insurance companies that are providing the same benefit plans but have different ways of managing those benefit plans, and you just cared for those patients in the best ways possible, made the appropriate community connections, that you would actually reduce the cost of care fairly significantly. And
Mhm.
we were able to demonstrate that in the early years, because in the early years, there was less barriers. There were less people forcing you in the wrong direction. And in the early years, we kind of proved, and you were there for part of it yourself, actually, we kind of proved that if you focused on quality, You got the patient's services they needed. You dealt with the fact that they only see a doctor for 10 or 15 minutes, but then they spend the rest of their lives unattached to that physician. And how do you build that community connection and that connection back to the main ship so that there's some continuity of care for those individuals? You can actually achieve all the things that people talk about today around reducing ED visits and unnecessary admissions and all that other kind of stuff, and bad things happening to people because they're not being paid attention to. You can actually lower cost. But we got distracted from that process over time because we have, multiple insurance companies managing the same book of business, Medicaid, for example, and we do that same thing in Medicare, and they all have their own rules, even
Yep.
though they work within the same basic
Yep.
government rule set. They
Yep.
have their own people managing different processes. They
Correct.
pay you slightly differently with different incentives and different models. And that's where the expense comes in,
Correct.
managing the complexity of the different insurance companies in your marketplace. You actually
Mhm.
may be lucky if you only have one insurance company in your
Right.
geography. Well,
Right.
we have 8 Medicaid insurance companies in New York City.
Mhm.
I've spent most of my career in New York trying to make one of those insurance companies the biggest in the state. And we actually were successful. We made
You
Health
were.
First
You
the
were.
biggest in the state. It's now got almost 2 million members, and it's extraordinarily well, doing well. It's got a 4.4, 4.5 star rating for 2 years in a row. And it consistently demonstrates that it doesn't matter what your socioeconomic standing is, you can actually do well if you do good. And that's kind of been the effort. So I think all of the things you mentioned, Lou, are opportunities that we kind of haven't put in place again. We were getting closer. And I kind of feel like we got a little bit off kilter right now, and now we're dealing with a loss of money. And now people are concerned about that. And how do you restore that? And are people going to be disadvantaged? And I don't have answers to those yet. We're going to have to live through that. But we're getting ready to live through it, and it's not all that pleasant.
Not all that pleasant.
Well,
I
I'll pause
agree.
and give Carrie a chance to chime in.
Yeah,
Yeah.
just real quick, I've got a couple of quick points, Vanessa, before we go to lightning round. So the first one is, one thing that I've always told my senior leadership and the board is that we have to be relentless on driving costs down. We have to be relentless at managing our costs, and that's across the organization, particularly administrative costs. If there's a way we if there's a way we can automate all this administrative cost that sits in the different insurance companies and their rules and all that kind of stuff, then we should be doing it. And that's why what excites me about AI, for example. The other thing is, as a nation, our cost structure is twice that of any developed nation as it relates to healthcare. That's a problem. That's something we're going to have to overcome somehow or another. The third thing is, real quick, is there's got to be a, a coming to the table by the big insurers. Frankly, I heard something very disappointing this week where the CFO of a major insurance company said they were working to get their swagger back. There's no place for swagger in healthcare. There really is not. And for them to make that statement publicly just seems just as it's incredibly disappointing to me, and it's also evidence of a system that is basically fractured, and we need to get better at it.
Thank you. Thank you, Carrie. Yeah, a lot of what we hear, what we see, what we're being asked is a reflection of where we're at. And it's very, very uncomfortable, right? And that's
Mhm.
why leaders like yourselves, like all of us, are in a position really of not only power, but we know enough. And Steve, you made this point to connect a lot of dots that not everyone has the opportunity for. And what I like to do to close us out as an opportunity of doing that is if you had the magic wand, right? If you have the magic wand, based on everything we talked about and what we didn't talk about, what is the single guiding ask? What would you ask your peers, your organizations, maybe yourself, those that are listening? What would be the ask, the one thing you would ask them?
My one clear ask, and this is probably the simplest solution, but sometimes by far the easiest one, is just to go to the people who are struggling the most. The people closest to the problem have all of the answers, and they just need to be empowered and provided with some of the resources to come together with solutions. All the time in quality improvement and patient safety in hospital settings, we bring together the experts, the clinical experts, the professors from different service lines, and very rarely do we bring up where patients will spend 99% of their time in the community. So we recently, last year, launched an Equity, Quality, and Safety Patient and Family Advisory Council. We pick people based off their home zip code and area deprivation index from the highest areas of economic affluence and to the lowest areas of economic privilege. And the conversations, we pretty much run all policies by, and this is kind of a question that I bring up, like, is this a policy that I would want my loved one to be applied to? And if not, it's not good enough for our patients. And I think it's just that proximity to the problem, the real idea of like, at the end of the day, of course, we have our financial operating orders. But when we push clinical efficiency against human dignity and say that that's our choice, that's a false choice. And that's one that we do not have to. There's ways in which we can improve both of those. And there's ways in which if we are only improving one without the other, then we're not doing it right. So I guess the simple path, by no means an easy one, is to be proximate to those who are struggling the most, and that can be very hard when you're often stuck in meetings with other executives and not on the front lines and not outside of the four walls of medicine, where my colleagues have said a patient spends 99% of their health journey in the communities, in the social circumstances that are creating these. And I just think it'll give you a whole new perspective on where the opportunities are. They're probably not on our Excel spreadsheets alone.
Thank you. Stay close to the problem, the Gemba, right? Jasmine.
My head went exactly where Lou's went, which is probably a reflection of, how much I admire Lou. And I
I
think we
know.
think very similarly in a lot of ways. Proximity was the thing that came to mind. And maybe, in particular, I had a baby this year. And so one of the things that I thought about a lot is I'd spent all this time researching maternal health and working with my team around building out these resources that we could share with health systems across the country, particular to Black maternal health. And then I myself experienced postpartum hypertension and did not want to go to the ER, right? Was like, I can't leave my kids at home. I have this baby, all of these personal life questions that really could have been a risk to my life, right? And sort of luckily came through that experience in one piece and really have been reflecting on that a lot about even in the best of circumstances, right? Even in a situation where I had childcare and a support network and a doula and all of these things, ultimately it was still a physician that said, I need you to understand how high the stakes are when it comes to something like this. And so even just that reflection around the perspective that can change when you're really thinking about how care matters, why care matters, the questions that you can ask yourself in the moment. I think those are things that we have to continually remind ourselves of as, folks who are looking to make a change in healthcare and in the operations of healthcare in this country. So proximity, and I think asking better questions of the right people would probably be my ask of leaders at this time.
Thank you, Jasmine. That's a bold ask. That's a bold ask. I like that. Stephen.
Listening to the two of you, it was actually nice to go third, at least. That what came to mind was to really tell my folks, as the world becomes more and more complex, as it will, with the introduction of AI and a whole host of other political barriers that are coming out, is not to lose empathy and kindness with the patients and the folks that we care for. Because they're working through fear. They are scared to death that they're going to die and that something bad's going to happen to them. And how do we recognize that and just, have the conversation, hold their hand, and get through that hump of dealing with whatever their current health situation is and how complex their whole picture may be, because their life beyond the illness may be causing or contributing to the overall challenge that they're facing. Just have the empathy, see the bigger picture, and then take a step back and think through what tools we have remaining that we can help better and improve that situation. So I always think of that.
Thank you, Steve. Thank you for reminding us of the why. And Jasmine, you hit on the why too, the birth of your baby too, but the why is so significant. That's what really, that's where empathy comes from, right? So thank you for that. And Carrie, final comment.
So I'm going to echo a couple of things that Dr. Hart said. First of all, that empathy is real important. And I look at it as, let's make sure and treat people like we would want to be treated. Treat patients like we want ourselves and our family members to be taken care of. If we do that, and if we really push that in our organizations, then we're going to have more empathy. We're going to have more of this empathy that everybody's looking for. The second thing is we have to walk the talk. I mean, there's something that I try to live by, which is it's called be the change you want to see in the world, right? Be the change you want to see in the world. If we can individually walk that talk and demonstrate through our actions and our approach to dealing with people and dealing with the processes, it will little by little help the world change as in a positive way. So that's those are my couple of things I'd say.
Thank you. Thank you, Carrie. It summarized this call so well. My call to action or ask is make the ethical decisions your priority, even if sometimes it goes against certain things that are happening or rules and policies. Give yourself permission to kind of break some rules this year. So that's my ask to myself and colleagues. I'm so grateful for you all for bringing your authentic self today and being so present. I hope the audience takes away a lot of the wisdom that I know I took in today, but also is able to build rich relationships and empathy as a result of this very rich conversation. So thank you so much, everyone, for tuning in, and thank you all, the speakers today, for such a wonderful session.